So good afternoon. So we will move to the next session. And one of the most difficult branch to practice for homeopathy is surgery. Because when will you cross the line and when will you not? There's a very thin line between a surgical and non-surgical. And there is still a confusion not only in homeopath but the fraternity of surgeon as a whole. So whatever is surgical cannot be managed with medical line of treatment are being managed by a homeopath from a medical line of treatment. But sometimes when we do not have discrimination, we let patient also into complications which are avoided. Now we are all on the learning curve and sharing these experiences of surgery which all of us are treating will give us a better insight into when, how, where cross the border, not to cross the border, because the final welfare of the patient is utmost. So the travel in this direction, Dr. Jigar, being a professor of surgery at Malini Kishore Sanghvi Homeopathic Medical College, he is a teacher from so many years, alumni of MLD MHI, and who had a privilege to work for the newer syllabus as well as the CBDC format which BHMS has, the NCH has just now released for second, third and fourth BHMS. He has worked for surgery. So it is a privilege to listen to him. We had a little difficult time while going through his presentation. Being a teacher, as a clinician and a clinical part sometimes dominate. So I will request him that please restrain with the restraint of time and focus with the objectives. Thank you, Dr. Jigar.
So thank you very much, the ICR, Kumar sir, Vipin sir, Prashant sir for giving me this opportunity. So topic is enhancing the outcome of surgical cases through standardized homeopathic practice. So objective of today's presentation is learning how the standardized processes helps in management of the surgical cases, experiencing the importance of psychosomatic correlations and how their interpretations help us in arriving at a totality of the case, learning how the accurate analysis of the case determines the correct approach totality and in terms helps us in enhancing the outcome of the case. So this is a 21-year-old homeopathic student who came with painful swelling with 2 to 3 openings with discharge serous black yellowish, modalities of aggravation touch, better by open air with mild fever. So there was tenderness and 2 to 3 openings. So what are the differential diagnosis? Folliculitis. Folliculitis will have a tiny pustules. The furuncle will have a painful red nodule with central necrosis, which is not seen in this case. Abscess will have a localized collection of the pus with fluctuant warm swelling, which is not seen in this case. So we are able to see multiple openings which is connected with each other. So we are managing a case of carbuncle. Now what are the complications of the carbuncle? Local, either it can go into the abscess formation, tissue necrosis, chronic non-healing scar, systemic like septicemia, bacteremia, and severe cavernous sinus thrombosis and metastatic abscess. So these are the all complications. So modern management is you treat early to reduce the complications of carbuncle. So incision, drainage and antibiotics is the modern way of management. So what role homeopath has in these carbuncle cases? So we have approached with Boger totality. There was characteristic discharge, serous, bloody, yellowish with carbuncle with typical modalities of aggravation touch and aggravation heat. So pulsatilla was selected, pulsatilla 204 hourly. So after pulsatilla, after 2 days, the fever was same, the pain has increased, discharge increased, so it became more yellowish and there was mild improvement in redness and induration. The modality of aggravation touch was available through and through, and the modalities has changed. Now you have got aggravation by draft of air and better by covering. So what are our interpretation of the case? The generals are not better and particulars are better. So disease has aggravated. So we need to review the case. So case was reviewed. The hypersensitivity which was available through and through, which we have missed, now it is classically available. The discharge is becoming more yellowish and now you have carbuncle in suppurative stage. The modalities of aggravation touch and draft of air and better by covering. So three remedies, belladonna, arsenic and hepar was coming up. The belladonna we have ruled out with early stages before the pus has formed and red hot swollen swelling. Arsenic will have got advanced stage with burning pain and blackish and gangrenous type of carbuncle. And here in this case there is classical hypersensitivity to touch was available and the case is into suppurative stage with modalities of aggravation cold and better by warmth. So Hiparsal was selected. The judgment of susceptibility was moderate, so Hiparsal 204 hourly was used. After 2 days, that is on 17/9, big pus pocket has came out and patient was relieved. And he has came personally to meet after 4 days that he was much better, almost pain is nil and one big pus pocket has came out on 15th night. So learning from the case how the standardized clinical approach to the acute infective surgical case help us to stabilize, correct appreciation of the follow-up assessment and reviewing the case help in better decision making, understanding the sensitivity of the case like hypersensitivity of Hiparsal which was available in the first prescription but physician has put more importance to the modality and therefore he has missed the hypersensitivity. So you need to look into the characteristic generals of the case, that is a learning, and how the judgment of correct susceptibility helps in quick recovery and it enhances the outcome of the case. So these are the learning. Another case, this is a case of 20-year-old male who presented with severe agonizing abdominal pain with nausea and vomiting. He was referred by one of the CHV worker. So there was a lot of hope from the homeopathy that homeopathic will help this patient. So history was taken. Now since almost 4 years, there is recurrent episodes of acute abdominal pain which used to come every 6 monthly. Now gradually the frequency has increased and now since 7 days it is almost continuous. Every 1 to 2 hourly pain was coming up. He used to cry with the pain. He was admitted in one hospital, but there was no relief in spite of the injections also. The classical modality was available, aggravation by eating, drinking, better by bending, double, better by lying with knee flexed posture. There is history of weight loss also, and this patient was non-alcoholic. Associated complaint of retrosternal burning chest pain, aggravated by sour food. The investigations was available. In 2016 there was UTI, 2017 there is pancreatitis. In January 2017 the amylase lipase was high with chronic pancreatitis changes, and now this patient has came to us. The report is available on 13th May which shows amylase and lipase higher. These are the reports. Sonography 2015 intermittent pancreatitis. The discharge summary July 2014 pancreatitis changes. Admitted on 2017 for chronic pancreatitis. To know the cause of the pancreatitis, MRCP was done which suggests dilatation of the pancreatic duct. So it shows that there is a case of chronic pancreatitis. So in short, we have got the history. A non-alcoholic patient of 20-year-old presented with this complaint, and on examination there was negative Murphy's sign. So what is our clinical understanding? What we are managing? Cholecystitis, pancreatitis or acute gastritis? So if we see cholecystitis, it has got a right upper quadrant pain, which is aggravated by deep breath and positive Murphy's sign with increased LFTs and increased WBC, which is not seen in this case. Acute gastritis has got typically epigastric pain with tenderness, negative Murphy's sign, and normal level of amylase and lipase. So we have ruled out this also. So pancreatitis, the case is having typical modalities of agonizing, severe upper abdominal pain, epigastric pain radiating to the back with negative Murphy's sign and increased amylase and lipase. So which shows that it is a case of pancreatitis. So now it is either acute pancreatitis or chronic. So acute pancreatitis which has got typical similar symptoms, but the clinical presentations are that the investigation of amylase and lipase is exceeding 3 times to the normal level, which is not seen in this case, and also the MRCP reports which suggest a chronic pancreatitis changes. Now, whether it is a chronic continuous pancreatitis or chronic relapsing pancreatitis. So, chronic relapsing pancreatitis has got chronic with acute flares, which is classically seen in this case where patient has got episodic pain. So, the management of chronic pancreatitis generally is you treat the underlying cause, give the pancreatic enzyme supplements and manage the pain. So, this is the whole management of chronic pancreatitis. Now, what are the complications of chronic pancreatitis? Either there is exocrine insufficiency in terms of weight loss, which is seen in this case. Patient has got already weight loss of around 6 to 7 kgs. Endocrine insufficiency, patient can land up with diabetes mellitus. Chronic persistent abdominal pain can be there. Pseudoduct formation, pancreatic bile duct obstruction, and patient can land up with pancreatic cancer. So now these are the possibility of the all your complications. So what role as a homeopath has, whether we could able to accept this case, with what clarity we should accept this case. So bogus totality was formed with typical locations, modalities. So remedies belladonna, Naxomica, colocynth were coming closely. Belladonna with typical severe burning, epigastric, intense pain, which is better by rest, aggravated by motion, has been ruled out. Naxomica, which has got a constrictive pain, better by warmth, better by vomiting, aggravated by stimulus, has been ruled out. The colocynth has got typical modalities of better by bending double and pressure, aggravated by eating and drinking. So by the modalities and pathology, we have selected colocynth. Now judgment of susceptibility was moderate, so moderate potency with frequent repetition has been done. So on 19.5, when patient has come to us, we have advised the patient to get admitted, but patient has refused, so we have given liquid diet and colocynth 202 orally. After 24 hours, the pain was subsequently better and he has tolerated all orally. So colocynth 204 orally has been done, and after 24 hours pain was 70% almost better. There was no complaint of nausea, vomiting. So soft diet and colocynth 200 QDS was done. So after 1 week there was no complaint, so we have defined the whole case. So these are the physical generals. In the life space, father, mother, both are cool, calm, they are living in a village. The patient was shifted to Baroda for study at uncle and aunt, but uncle and aunt both are very irritable. There was incidence on 11th standard, there was verbal fight with the aunt, and in that patient has got irritable and retaliate, and this incidence uncle has heard, and uncle has scolded the patient, and this was the stage where patient could not retaliate. So there was suppressed anger and humiliation and vexation feeling, and since then the complaint of pancreatitis has started. So basic nature of patient is very irritable, reserved. There are a lot of anger which has been suppressed and vexed feeling. So ET was formed where the centrality you could able to see irritability, vexation, reservedness, and on incidence of 2012 there is anger suppressed and humiliated feeling with somatization on the pancreas with modalities of aggravation, eating and bending double. So the question was that whether colocynth is acute or a chronic one. So after this we have chopped down the totality, done the repatriation. So remedy which was coming up with Naxomica, Colosin, Staphysagrea very closely. So if you are able to see the anger of the patient and what is the expression of the anger. So Naxomica, basically irritable, explosive, quarrelsome patient, which is from the frustration and contradiction and business worries. The expression of the anger is he will become snappy, critical, abusive, he will throw the things, and effects on the gastric mucous membrane. So this is not classically seen in this case. Staphysagrea will have got a lot of anger, but it is silent brooding with anger, with insulted feeling. The cause is repressed insult and offended pride. The expression is he is polite outside, but internally there is lot of burning, with the expression of trembling and tissue affinity of bladder and tooth. Whereas in this case we have seen suppressed anger with indignation, with characteristic expression of anger in terms of he tries to suppress his anger, and there is crampy abdominal pain, and classical modality of better by bending double and better by pressure. So on screening we have given Colosin, patient was better. On case definition we have thought of through ET that it could be Colosin could be constitutional. We have repertorized, differentiated and come to conclusion that Colosin is the constitutional remedy of the case. So we have continued Colosin 200 QDS, then TDS and then gradually BD twice a day. Sonography report came to normal on May 2018 with all investigation normal. Since then there was no acute abdominal pain, there was no need of admissions of the patient. So we continued for almost 1 year, Colosin 200, BD, then OD, and then patient was completely better. These are the follow-up sonography reports. 2018 May, normal sonography. So what is the learning? So how standardized, when you follow the standardized process of receiving the case of acute abdominal pain, how it helps us in clinical understanding of the case, right from diagnosing to differentiating and then managing the case. Correct interpretation of the stage and stage of disease is very, very important for accepting the case homeopathically. That we could able to see from the case, and how the EET as a standardized tool helps a physician to balance itself and come to conclusion that acute can be your constitutional force, and which really help this patient to settle very fast. And most importantly, how the anger, different remedies of anger and the expression of the anger, we can able to differentiate various remedies. So this is another case. This case was referred by a RMO. He is a 67-year-old Muslim male. He had since 1 year non-healing ulcer. In spite of taking all allopathic medicine, the ulcer was not healing. He is a vegetable seller. So chronic ulcers, when the ulcer is not healing more than 4 weeks, so we need to differentiate various causes of ulcers. Whether the ulcer is because of chronic venous insufficiency, or infective cause is there, or localized destructive cause is there, or there is neurological cause. So we need to approach the case with history taking and clinical examination and investigation. So history was taken, where you could able to see the march of evolution of the disease, right from 5 to 6 years, diabetes to gradually cracks, to autonomic nerves with erection poor, with involvement of the peripheral nerves, tingling, and non-healing ulcers since 1 year. So physical examination was done. Both the foot has got decreased sensation. Investigation, X-ray was done to rule out the osteomyelitis. That was normal. Sugar, WBC was normal. So what is clinical diagnosis? We are managing a case of diabetes in complicated stage with peripheral neuropathy with non-healing ulcer. So what role a homeopath has? How it should approach this case? So we have approached this case by defining the whole patient as a person. So this patient has very poor financial condition. The father was principled, hardworking. He has introjected all the quality of father. So right from the childhood, he was very much hardworking. There was an incidence of quarrel between brother 2 and patient. but he could not express his anger, because what people will say about if he expresses anger. So the kind of image which father has lived his life, he has introjected all the quality of father. So there was image consciousness and value system, hardworking, loyal, helpful, aggravation by disrespect, image conscious and value system. So non-repeatable approach was done. Silicea and carcinosin were both the drug coming very closely. But if we able to see the tissue affinity of silicea and carcinosin, silicea has got tissue affinity on cellular elastic tissue, glands and skin and mucous membrane with chili patient. So silicea was selected. Judgment of susceptibility, the age of the patient was old, fast pace of disease. We can able to see the case in complicated stage within span of 5 years. So low potency with frequent repetition was planned. So this is the first day where silicea 30 2 times in a day was used. After 7 days, the kind of response was that all observer, student, learner, all were surprised and shocked that 1-year-old ulcer, how the recovery in 7 days could occur. All other symptoms is also better, like constipation, other leg pain, hand pain, all were improved. So we have continued, and after 1 week, there was very fast recovery. All other generals were also improved. So we have tapered to silicea 37 packet, and within 35 to 40 there was completely ulcer which was healed. So learning from the case, how the application of the all standardized process of approaching the case, not from clinical, also from homeopathic standpoint of view, helps us in quick recovery of the case. We need to understand what is the man behind the pathology, and it helps us in understanding the patient as a person and totality of the case. In this case, we have understood the importance of non-repertorial approach and how the correct assessment of susceptibility helps in quick recovery and enhancing the overall outcome of the case. So overall conclusions, for surgical case demands the interpretation of the clinical stage and state of the disease with due consideration of the complication of the case. What case I am handling at what stage, and what are the chances of complication, and whether complication has set in or it will set, and what precaution procedure from angle of susceptibility I will take to be similarity with the susceptibility of the case. All the standardized processes in approaching the surgical case require right from case receiving to case analysis to case synthesis that we have seen in case 1 and 2. And for enhancing the outcome, we need to follow the standard processes. Standard processes written in clinical surgical textbook, and then integrating them with our philosophy of homeopathy that helps right from clinical history taking to investigation to overall judgment of the susceptibility. And overall standardization of homeopathy is an ever evolving phenomena. So one must follow the system and process. If you do not follow the system and process, the evolution cannot take place and standardization will be at a mirage. So that was the things. So I will thankful to Kumar sir, Bipin sir, Prashant sir, and all ICR, my teachers who have trained me, my patient who has given opportunity, and student who are ever observer. Thank you.
I think this was a great effort as far as I look at it from a standardization point of view and the flow and all the questions which visits homeopathic physicians were being raised and tried to be solved at certain level, but we all must go back with all these questions and explore our surgical patient so that we can further evolve the standardized approach to surgery. Thank you.
Great.